morning, friends. Today we bring you the coverage of day 2 from Prague, European Society meeting on heart failure 2023. Today we had very exciting presentation at Prague, and let us look at what did we learn. The first interesting data of HFA Express day 2 was this. The therapeutic management of heart failure with preserved ejection fraction, HFpEF, with a specific focus on patient profiling. This was presented by Dr. Stefan Anker from Berlin, Germany. So HFpEF patient profiling. Now we all know that HFpEF patients come in different subsets, and they are a heterogeneous group of people, right? So we know that they can have, for example, arterial hypertension. They can be elderly, more than 65. They could have coronary artery disease, about 40 to 70%. Women comprise about 50% of HFpEF. Chronotropic incompetence with a slow heart rate. They can have obesity. They can have iron deficiency. They can have sleep apnea, OSA, and of course, type 2 diabetes and CKD. But what we don't realize is even beyond the standard ones, we have huge unseen subsets. Hypotensives, ejection fraction, high or low, COPD, yes, no, cachexia, AFib, pulmonary hypertension, faster heart rate, functional TR, and a lot more, right? So it's a very, very heterogeneous disease. And that is the first thing that we need to understand. But in that complex scenario, if we are looking into the treatment as to how we proceed, we need to keep the SGLT inhibitors, dapagliflozin and empagliflozin, in the center, with a diuretic if the patient is congested. So we are looking at the patient phenotype profiling, heart failure, with an idea of how to treat them and trying to simplify the complex problem that we just now saw. For example, if you have an ischemic heart disease, choose beta blockers, calcium antagonists, ranolazine, trimethoprim. If we have atrial fibrillation, choose an antiarrhythmic like Trivandrum, imidrone, or do a pulmonary vein isolation procedure. If you have type 2 diabetes over and above SGLT inhibitors, think of GLP-RAs, metformin, and finerenone. If you have hypertension, think of RAS inhibition, diuretics, beta blockades, MRAs, and calcium antagonists. If you have obesity, think of semaglutide. If you have COPD, think of LAMA and LABA in association with beta blockers. If you have iron deficiency, think of repletion in the iron with ferric carboxymaltase. So when you are looking at treatment point of view, it's far more simpler than the very complex comorbidities. You have your specific patterns to choose and treat. From that, we come to the next presentation, which is a little more confusing. The question of worsening heart failure. Many people don't understand the very definition of worsening heart failure. Okay, now this was presented from Italy. Worsening heart failure, Dr. Marco Metra. Worsening heart failure is defined as a worsening of symptoms of heart failure. So this is not new onset heart failure, but worsening of symptoms of heart failure. We require intensification of treatment, generally including diuretic escalation. So these are worsening of symptoms. Patient already has symptoms of heart failure before. Now there's worsening of symptoms. You need to intensify treatment with a diuretic. And this occurs in patients who have pre-existing heart failure, obviously, which means we are excluding patients with new onset heart failure. So a patient who didn't have anything till yesterday has a new onset heart failure. They're clearly not worsening heart failure. They're excluded. Also, if your patient had a worsening because of a concomitant factor, a comorbidity, or kind of poor compliance as a primary driving reason for this readmission or worsening of symptoms, they're not included. So basically, the disease has worsened in already present heart failure, and that is worsening heart failure, or WRF. Right. Now, if you look into the data and look at the prevalence of this is timeline, you see the years 2010 to 2019 in the x-axis. Look at that. If you take out all worsening heart failure episodes, you see they're pretty high. And over time, they're gradually increasing. And that sounds an alarm bell, right? Over the years, worsening heart failure, despite our newer therapies, is gradually increasing. And if we look at them from a specific point of view, for example, if we take out those who were hospitalized for worsening heart failure, right, a very strong, solid endpoint, and divide them into those patients who are presented outpatients. See, in that outpatient group, you are 8.2% hospitalized for worsening heart failure. Look at those who presented in the ER. 10.6% of them were hospitalized for worsening heart failure. Look at patients hospitalized for worsening heart failure episodes. 12.4%. Which means, yes, it is very important that we prevent worsening of heart failure. And we don't lose the window of opportunity here. So what do we do? What are the treatment options available? Okay, in the hospital, in the ER or outpatient, yes, we have treatment of congestion. Understand this patient is already on a diuretic therapy, to switch to an intravenous loop diuretic. That is the commonest approach that we do. We can also switch or add acetazolamide or a thiazide or thiazide-like diuretic like a metronidazole to the already present loop diuretic. Of course, we can treat hypoperfusion 8% by intravenous inotropes or the newer inotropic agents that are available. So, treat congestion, hike diuretic, loop diuretic dose, switch to IV loop diuretic, add acetazolamide, add thiazide-like diuretics like metronidazole. Right? And what about prevention, which is far more important? If we have a patient who had a previous heart failure, how can we prevent worsening heart failure? The first thing, obviously, see that your patient is on good neurohormonal blockers, ARNI, beta blockade, and MRA. Make sure that your patient is on SGLT inhibitors, TAPA or MPA. See if you can correct iron. If your patient is iron deficient, try to correct with iron therapy. And if you still feel there is worsening of heart failure admissions, think of SGC stimulators like vericiguat. So we have a lot of preventive measures and a lot of measures in treatment of worsening heart failure. That brings us to the next topic of fixed dose combination therapy. Today we are talking about a poly pill, right? In the treatment of hypertension, in the treatment of diabetes, where you have one single pill with multiple chemicals in it to increase compliance, right? Because polypharmacy has its problem. What about heart failure? What about heart failure? Now, if you see the data, those of heart failure patients without polypharmacy, that is less than 5 medications at baseline, they do better over a 1 year period. That blue line, right? In contrast to the red line, where more than 5 medications were given to the patient. And today we know that heart failure really needs polypharmacy, right? So a new trial is being planned, a fascinating one, and that is polypill for heart failure. And what the polypill contains? A beta blocker like a metoprolol succinate, 25, 50 or 100 or 150 milligrams, with a spironolactone of 12.5 and an empagliflozin of 10 milligrams, with a background RAS inhibitor. Right, so background RAS, a metoprolol, spironolactone, empagliflozin given together. That polypill will be compared to an usual standard therapy of the drugs given separately, right? And what do? These would be done in settings of county hospitals and to a diverse uninsured population, right? And at the end, you look at results. What are we intending to see? Change in left ventricular ejection fraction, assessed by cardiac MR. Biomarkers like NT-proBNP and patient symptoms of 6-minute walk distance and KCCQ. So we're trying to see that by giving a polypill, reducing the number of pills, does the patient do better? Does his NT-proBNP improve? Does his LV ejection fraction and cardiac volumes change? And does he really feel better? From there, there was also one slide, we thought we would project that about something called de-prescribing. We know that one has to be careful while de-escalating drugs in heart failure. We know that, there's enough data. But there are situations when there are non-needed polypharmacy. A patient may not need a particular drug anymore because he might have become better, he might be treated with a device therapy, or whatever may be better. Second, Deprescribing needs to be thought of when there's an adverse drug reaction. The patient may not tolerate an SGLT inhibitor, or RNA, or MRA, or whatever drug they already beta blocking. Right. Think of deprescribing for end-of-life care, right? When we are just giving palliative care, we don't need to overload the patient with too many medications, which might not be useful at that point of time. And prioritization of other diseases. A patient might have a failing heart, but he might have a metastasizing cancer. He might need intense pain, or he might have a chronic liver disease or a COPD, which might be his dominant symptom that we need to keep in mind. So the take-home message here was adherence to heart failure treatment is often limited. Polypharmacy leads to discontinuation. More drugs you give, more discontinuation. So polypill has been shown to reduce cardiovascular disease in coronary artery disease, the acute coronary syndromes, right? Polypills are established. So the point is, will polypill be beneficial in heart failure? And most people believe, yes, it would. Non-suspending drugs can be as dangerous as non-prescribing. There are some situations where you need to cut down on the number of drugs prescribed to the patient. Careful assessment of medical therapy and a potential interaction between the agents need to be done at every medical encounter. Then, of course, we had a very interesting data on standardized diuretic protocol. The trial is called ENACT-HF, ENACT-HF trial. Now look at that data. It's a prospective multicenter open-label non-randomized trial between a standard diuretic therapy in heart failure versus a protocolized therapy, the algorithm-driven therapy. Right. And there was 2 sequential phases of recruitment. We will show you how it was done. Now, we know that in most centers on admission, when we prescribe a loop diuretic, day 1, day 2, day 3, right? Most of it is determined by the urine output by the physician's discretion. The physician decides, okay, good urine output, de-escalate, or less urine output, escalate therapy of IV diuretics, right? Now, contrast to this, in some centers, they had gone for a protocolized therapy, a phase 2. Protocolized therapy was more complicated, but then it is something like this. If the urine sodium, for example, was less than 50 millimoles and the urine output was less than 100 ml per hour, you double the IV loop diuretic, right? So low sodium, urine sodium, and a low output, you double the loop diuretic. So it was an entirely algorithm-driven treatment. So a physician-directed treatment where it was like the physician felt, or an algorithm-driven treatment. At the end of the trial, when they looked at natriuresis after day 1, they found that in the red, protocol-driven group had a better natriuresis. So yes, the protocolized group had a better outcome by way of natriuresis, which was the primary endpoint of the trial. What about duration of hospitalization? This is more important to us. We don't care whether how much salt the patient uses, right? And if you look at that red bar, the protocolized group, protocol-driven group, algorithm-driven group, had a 1-day lesser hospital stay compared to the blue bar, right? Which means their hospital stay was less. So yes, it is worthwhile following the standard protocolized loop diuretic therapy rather than the physician discretion. So ENACT-HF trial showed that a protocol-guided diuretic therapy had a 64% increase in natriuresis after day 1. But to us as clinicians, more important is it led to a shorter duration of hospital stay. I mean, that is more important to all of us. And finally, the last trial we will discuss is dapagliflozin in health status. Okay, this is the spectrum over the spectrum of ejection fraction, a combination of data, combined data from DAPA-HF of HFrEF and DELIVER, which is HFpEF. So dapagliflozin over the spectrum of HFrEF and HFpEF, did the patient actually feel better? Now, this is a very important question presented by Dr. Ankitas Bhatt on behalf of the co-authors of DAPA-HF and DELIVER trials. Look at the data. If you look at total symptom score, or if you look at clinical summary score, we are looking at KCCQ scores, right? Or overall summary score, or the physical limitations, whichever way you look at it, all of them showed that the dapagliflozin arm in red had a better outcome. So dapagliflozin treated patients had a better symptomatic score, clinical summary score, overall summary score, and our physical limitation was better when treated with dapagliflozin compared to the placebo arm. Right. But as a clinician, we did learn something even more important. I think this is very important. Now, if you look at those who had LVEF less than 40, HFref, right? Now that red part you see the time when they were hospitalized, and the rest is before hospitalization. If you see their symptomatic score, within about 3 months of their hospital admission previous, so prior to their hospital admission, there was a dip in their symptomatic status. Interesting, right? So before they were hospitalized, a month before, they had a dip in their symptom, a worsening of symptom. So it might be a clue to us that the HFref patient might get hospitalized soon. And maybe a warning that we need to intensify therapy or individualize therapy. Right. What about those with higher ejection fraction? Deliver. EF more than 40. Same pattern. Look at that. There was a dip in symptoms prior to hospitalization. So this tells us that yes, prior to actual hospitalization, be it HFpEF or HFref, there's a dip, worsening of symptoms. And that might be a warning sign that the patient is going to get admitted. So at the end, the conclusions of this trial were dapagliflozin improved health status by multiple KCCQ measures. Improvement of health status was observed consistently across the full range of LV ejection fraction, be it HFpEF or HFref. The patients on dapagliflozin were less likely to experience meaningful deterioration, more likely to experience small, moderate, and large improvements in health status. But more importantly, KCCQ steeply declined prior to hospital admission in the previous 3-month period prior to the hospital admission, which might give us a clue that he might be worsening and get hospitalized. Now, these data support the treatment with dapagliflozin to improve symptoms and quality of life, patients of heart failure across the spectrum of LVEF, especially the patient shows a dip or a deterioration of his symptoms over time. That brings us to the end of day 2 from Prague, Heart Failure 2023. Thank you for being with us, and we'll be back with the third day's proceedings tomorrow. Thank you and bye.